So I'm going to talk a little bit about the equipment itself and what's involved in doing a MIP. I think once you're armed with the tools for access, which Dr. Sir gave a really nice talk on, and the shifting towards ultrasound, I'm going to just touch on the tools and how you can take advantage of them and what would the potential benefits be over another system. So the MIP set, which is the minimally invasive PCNL, this is a picture of the entire set. It's nice because it's a modular, reusable system. So everything that you need, for the actual procedure is here. Now, obviously, there are some additional equipment items you need for getting access and for performing lithotripsy. But in general, the equipment for dilation, navigating the kidney, there's even a grasper that comes with the set for stone removal. Pretty much the majority of the equipment that you need is contained in this set, and it's reusable. That potentially translates into cost effectiveness because you are cutting down on your needs for disposable items. And it can facilitate a tubeless PCNL or even an outpatient PCNL because of the size of the tract. In the United States, there's three main size sets designated small, medium, and large, or a MIP-S, MIP-M, MIP-L, and that really refers to the size of the nephroscope, the camera. So we primarily use the MIP-M set, which is a 12 French scope, and it comes with three different sheath sizes that range from a 15 or a 16 French, 17.5 French, and a 22 French. And you can see those laid out here. Each sheath comes in two lengths. There's a regular length and then a length designated with an S for supine, which is to facilitate if you're doing the case in a prone versus a supine position. It's slightly longer to account for the increased skin to stone distance for a lower pole in the supine position. So once you've picked a size, the equipment that you need is shown here. All you really need is a single step dilator. You can see in the video, that's me putting the dilation obturator through the operating sheath. So you need your sheath, you need your dilator, you need the nephroscope, and then possibly a sealant applicator to close the tract when you're all done. And again, it's a single step dilation, which we'll come back to, so it simplifies the process. So some key features of the MIP set. Obviously, its size is very advantageous compared to standard PCNL, which often are either 24 or 30 French. Dilation tracts, you can make a much smaller tract here. The single step dilation we talked about. One advantage of this set is that it's an open system design. What I mean by that is the sheath itself and the telescope are not locked together. So you can see in this picture, by maintaining freedom of movement of the camera, independent from the outer sheath, it maintains an open channel for outflow around the nephroscope. So by doing that, you can really maintain a lower pressure state in the kidney because you're not at risk for blocking the outflow, which could lead to increased pressures inside the kidney. That also facilitates stone extraction using the vacuum effect, which we'll touch on in a minute. Obviously, this system allows you to close the tract after with sealant if you want. And then there's a large angle of view relative to the scope, and that's because the nephroscope itself is very small compared to the diameter of your access sheath and the angulation on the camera. So it translates into a very good visibility inside. So the vacuum effect, I think this is one of the main advantages of the MIP is it facilitates fast removal of stones, of both dust and also small particles. The idea is the inflow through the nephroscope, as shown by this red current, creates an eddy current approximately 1 to 2 centimeters in front of the tip of the camera. And then the draining fluid, which comes outside the sheath, because of the physics of that interaction, creates an eddy current right in front of the camera, which you can use to trap stones. And by withdrawing the nephroscope, you're actually withdrawing larger stone fragments in this eddy current. And then the continuous flow promotes smaller dust and fragments to also drain on their own at the same time. An advantage of this is it could potentially is faster, and you don't need to use disposable retrieval devices such as baskets and graspers. This is a video from Dr. Sur that highlights this effect. And you can see here there's a nephroscope is inserted, and you can see the continuous drainage of fluid around the sheath. And then as you bring the scope back, you can see the stone pieces are coming out, landing on that gauze pad beneath the camera there. And you can see on the right, there's a stone that's being trapped right there, and it's held about 1 centimeter in front of the scope all the way as it's being withdrawn. And some of the subtle tips are, as you're withdrawing the stone, you want to tip your wrist so that you can maintain that vacuum effect all the way to the end of the sheath. And you can see in a pretty short time, he's already pulled out, there's at least 8 large stone fragments visible on that gauze. So if done right, it's a very fast and efficient step. So I'm going to just go through quickly the steps of the procedure overall, and then show you sort of one option for technique and how to use the system. So the first step obviously is to get ureteral access, and this can be done depending on how your setup is. I personally do a cystoscopy, place a ureteral catheter, but you can also do a retrograde ureteroscopy. This is a picture showing the table setup. So you can see in my case, I've selected the MIP-M set. So really all I have is my sheath, my dilating obturator, and my nephroscope. And then I have a few other things that come with the OR, and my access needle is over here. I have some methylene blue. I have one suture for the end of the case. So I do prone positioning. So after we've placed a ureteral catheter, we then put the patient in prone position, and you can see I have a setup similar to Dr. Sur's illustration. We have the C-arm up here to complement access, and then the visualization monitors, and then at the foot of the bed is the ultrasound monitor here. This is just shown with the lights off. You can see there's a nice view. So step 2 obviously is obtaining access, and this can be through a variety of techniques. And once you, the key is obviously getting access with, here's a flash of urine. In this case, we've used methylene blue. And then you want to pass your wire either into the kidney or ideally down the ureter into the bladder. This is the single step dilation, which is one of the hallmarks is once you have your wire, you twist your obturator over the wire in a slow fashion. You can use fluoroscopy to guide it. And when you're in, you can see there's a second port that we're alluding to here, and that will drain urine. So you know the obturator is in the right place. When you see urine coming out, you then pass a second wire through this channel. Once you've done that, you actually withdraw the dilator off of the 2 wires and reinsert it just over one of the wires. And that's so that you can maintain a safety wire outside of the tract. And here you can see we're advancing the sheath over the dilating obturator. And you can see the sheath there once it's confirmed inside the kidney. Then you can remove the working wire and the inner obturator, and you have just a working sheath with a wire, safety wire outside of that system. If you're having difficulty, there's other maneuvers you can use. You can possibly use a 10 French or an 8-10 French dilator to pre-dilate the tract prior to passing the dilator, or even a balloon. The next step is treating the stone. So this is using either a laser or a lithotripter of your choice. Commonly, I think people use some form of laser. Nowadays, I do think that the Moses or a dusting laser or even a thulium, any of these higher energy laser systems that enable dusting of the stones, potentially will lead to faster drainage due to the vacuum effect of the MIP. You can both extract the stones as we've seen and also drain all the dusting and the small stone fragments. And then at the end, either leave a nephrostomy tube, although this system, to be honest, really is geared for leaving an internalized ureteral stent. potentially even going totally tubeless. In our practice, we leave a stent with an external tether. So we place the stent and then leave the string externalized through our tract. This facilitates easier removal. 3 to 5 days later, the patient comes into the office. One of the nurses just removes the stent by pulling the string. It also saves the patient having to undergo a cystoscopy, which many men are particularly excited about. And you can see here that there's just a Band-Aid left behind.